Thank you very much for having me. This is a pretty short talk. Kristen's already given a great introduction on chemical injuries with airbag injuries, and we'll sort of go into some photos and things that I have here. So a little bit about epidemiology of chemical injuries. 10 to 20% of all ocular injuries actually have some sort of a chemical base. When I saw this number, I thought it was a little bit high. When we see patients in the ER, I can't say that 1 out of 5 to 1 out of 10 patients that we see tend to have a chemical injury. But the fact is most chemical injuries never make it to the ER. They're actually just treated at home by the patient self. They might come in a week or so later with a little bit of irritation, more of like those splash injuries that are just flushed out by home, contact lens cleaning solutions, etc. 2/3 of them are young men, as I think she mentioned with 3 young boys. And alkali injuries far outweigh the acidic injuries. Acidic injuries are those with a pH of less than 7. These are actually a little bit milder than the alkali injuries because they denature the protein, so it creates a coagulative barrier on the surface of the eye that the chemical can't actually penetrate further through. The only exception is hydrofluoric acid. The fluoride ion rapidly penetrates through the eye, and it's probably one of the most devastating injuries that we've seen, and I have a photo of one a little bit later on. The treatment is still in question for what to do for a hydrofluoric ion injury, but the thought is to use like a calcium gluconate drop and just sort of flush with calcium to get rid of the fluoride. An alkali injury, on the other hand, which are far more common, are lipophilic injuries, and so they penetrate the cornea quite well. They penetrate into the trabecular meshwork. They saponify all the lipids in the cell membranes, including the intraocular structures. So this is the chemical injury classification system of Roper Hall from the early 70s, and it's basically broken off into 4 stages. And the key for this is, again, limbal ischemia. You can see that's sort of like the dividing factor for how to distinguish chemical injuries. The photo that Kristen showed of that young child that had an injury from the Drano on an aluminum foil was pretty severe, but he did quite well because he was young. The more modern classification system is the Dua classification. I think Harminder Dua has been more recently brought to fame with his identification of the Dua's layer. This is about a decade ago in the early part of the 2000s when he had proposed this classification system. And again, it's highlighting the fact that if you can identify how much of the limbus is involved, it's going to tell you a lot more about prognosis than many other features. And regardless of how you look at this with conjunctival involvement, number of clock hours, or on an analog scale as a percentage of the limbus being involved, it's pretty much separated into 3 clock hours. If the eye is beet red and there's no limbal involvement of ischemia, the prognosis is very good, regardless of what the other findings are of epithelial defect, corneal haze, pressure, etc. By the time that you have the entire limbus involved, or 100% ischemia around the conjunctiva, or a grade 6 injury in this classification, the prognosis is quite poor in these patients because the injury has already really seated in deeply. This is a photo of a gentleman that we saw when I was a fellow at Bascom Palmer with Terry O'Brien. This one is actually from hydrofluoric acid. His eye, while it is beet red, the fluoride ion not only penetrated into the eye, but it perforated a hole in his cornea. And this was actually something that we had literally watched happen from the time that he came into the ER and was seen by the resident, and we had come in to see him for this. He was actually glued, and this is his eye about a week or so later. And he actually ended up doing reasonably okay in terms of his cornea. This finally did fall off, and he ended up with a graft and did okay since his limbal stem cells weren't quite that badly injured. This is another injury that I saw with Victor Perez. This is a chemical injury of a gentleman with a pretty severe chemical burn. This photo comes actually in a set. You can see a little piece of tape that's taped to his nose. The injury that he ended up having was more of a caustic gas injury. It was a liquid that sort of became into a partial gas state, and it burned not only his eye, but his airway, the inside of his mouth, his throat. He ended up with a pretty bad skin injury, so he has an NG feeding, like an NG tube put in, as well as is being evaluated by anesthesia for airway support. So as was mentioned in one of the first talks, the most important thing to figure out is whether this is an isolated eye injury and the chemical has only affected the eye, or it's actually penetrated all the way through. So for this gentleman, he was transferred to the ICU, so we managed him with Procera, which I'll talk about in a little bit. And this is a fluorescein photo showing a little bit more of the epithelial defect of the injury. So what are the principles of chemical injury management? The first thing is to irrigate, irrigate, irrigate. Regardless of when the patient makes it to you, the most important thing to do is just flush out whatever is there. The basic principles of management in the long term are promote epithelial healing, as many of these patients have epithelial defects, find a way to control the inflammation and thereby limit the damage that's done in the long term weeks out from the initial injury, prevent an infection in the presence of an epithelial defect, control the intraocular pressure because many of the alkali chemicals will penetrate into the trabecular meshwork, causing a trabeculitis, and finally control the pain. And I find that this is something that's often overlooked when patients have come in to see me in the office a day or two after their initial injury. So again, irrigate, irrigate, and irrigate. I think the Morgan lens is a great way to irrigate these patients. Hooking up an A-line kit with a balanced salt solution bag and having somebody sit there and squirt water on the cornea is also pretty effective, but it's also very time-consuming. Putting a Morgan lens in with a couple of drops of topical anesthetic really does work pretty well, and this way it doesn't require somebody sort of spraying water or BSS on the cornea. There have been studies that have compared normal saline to lactated ringers to BSS+, and BSS+ is found to be the most comfortable irrigant, if you will. However, it's also the most costly for these to use in this particular fashion. And after you've had a chance to check the pH, sweep the fornices for particulate matter. A lot of lye and concrete injuries will actually precipitate out particulate matter on the palpebral and forniceal conjunctiva. So for a grade 1 or grade 2 injury, the treatment that's recommended is antibiotics, and for many times I'll prefer a drop over an ointment form because if there's particulate matter, you don't want that to sort of emollient to stay on the surface of the eye. The more that you can do to continue to flush the ocular surface, the better off it is to get rid of any sort of microscopic particulate matter that's been left on the ocular surface. Cycloplegia can offer comfort for these patients that have had a penetrating alkali injury. And frequent preservative-free artificial tears. Again, the principle being you're still continuing to flush the ocular surface. There is some question about how best to use steroids, and chemical injuries cause a lot of inflammation. So the recommendation is usually for the first week, a steroid is very appropriate. It decreases proteolytic damage that can incite from any sort of chemical alkali or acidic injury, and prednisolone acetate is a reasonable steroid to use. After a week, when you start becoming concerned about a corneal melt, then the question becomes, would you switch the patient to or rapidly taper them off the steroid? Medroxyprogesterone can be compounded. It's a progesterone-based steroid, and it's been shown to decrease the melting of the cornea when compared to prednisolone acetate. Other things to stabilize the corneal collagen matrix are vitamin C. 2 grams 4 times a day is the dose that's been studied. I know many people use a much lower dose, but this is actually the studied dose of vitamin C. And then doxycycline orally is a matrix metalloproteinase inhibitor. And so this can also help to stabilize the cornea, much as it does in corneal ulcers. For a grade 3 or to grade 5 chemical injury, not only do you do what you do for a grade 1 or 2 injury, but there's a few extra things. The first is if you see necrotic epithelium hanging on the cornea or even necrotic stroma, it's worthwhile using a Kimura spatula or something just to debride it off. The less damaged or diseased things that you leave on the cornea, the less inflammation that you'll incite on the ocular surface. So just like a gentle debridement is usually pretty helpful. And then there's a role for amniotic membrane. They now have available Procera Plus, which is a double-layered amniotic membrane wrapped around the ring. This can work pretty well in ICU patients in particular because it lasts a little bit longer. I'm sure many of you have had the experience in chemical injuries of putting a Procera ring on, and while it's supposed to last around a week or so, the patient comes back the next day and 80% of the ring is already melted away. The double ring, I haven't used it yet because it's only been, I think it only came out about a month and a half ago. But in theory, if you have double the layer of the amniotic membrane, it should last a little bit longer. The ring itself can help with some blepharon formation, but like I mentioned, you should find some way to control the inflammation in a much more efficient way. So this is an injury, a chemical injury of a patient that ended up with, I believe it was a sodium hydroxide injury, that has a pretty significant amount of limbal ischemia if you look around the cornea, and there's quite a bit of haze that started to set in this particular patient, suggesting a pretty devastating, somewhere between a grade 4 to, grade 3 to grade 4 injury here. This, on the other hand, is a grade 5 injury, or a grade 6 in Dr. Dua's classification. The cornea is completely opaque and the limbus is completely ischemic. This patient has an extremely poor prognosis. So we're going to shift gears for a moment and talk about thermal injury. This is a patient that had a fire. This is a firefighter actually in Miami that ended up with a rather devastating facial burn when he ran into a fire without the appropriate protection when he was off hours. Off duty, I should say. So the difference in management of a thermal injury, which really does change from a chemical injury, is there's a lot more eyelid-related injuries to contend with. And this really speaks volumes to getting the oculoplastics folks involved at a much earlier point than you would consider. The cicatricial injuries that happen from a thermal injury are very devastating to the eyelids. And even in the long term, the more that the lids will cicatrize, the worse off the cornea and the anterior segment will be. The practice for a thermal injury is similar to other immunological burns like Stevens-Johnson's or toxic epidermal necrolysis in patients that have had a drug exposure. The key is to remove the burned eyelashes and the eschar, and in an acute injury, there is some role of using a chilled irrigant solution to cool down the lids and the ocular surface. None of that has been shown to decrease the cicatricial changes that will ensue in the eyelids, but it is something that can help to support the ocular surface while you're waiting on the lids and some sort of a temporary measure to help protect the globe. If you'll notice in the photo before, the way that we were protecting the globe was simply with tape tegaderm. And as I think was earlier mentioned, also is a tetanus toxoid in many of these patients. So we'll talk about ProCare and then a couple of the novel things that are being used now and being studied for the treatment of chemical burns. Amniotic membranes have been harvested from the placental sac for treatment of ocular surface and ocular surface reconstruction for quite some time. Schaefer Sang has published quite a bit about this utilization. The studies that he has shown, which really haven't been well duplicated, show that if you use it within the first 2 weeks, they can have some sort of a benefit on the rapidity of the healing of the corneal surface. It doesn't really affect the final outcome in the treatment course of a chemical injury. It simply makes it happen a little bit faster. However, if you don't apply something within 2 weeks, the damage is pretty well irreversible. The two versions that are available are a dehydrated version and then the cryopreserved ProCare version, which is made by BioTissue. This one will maintain the cytokines, unlike the decellularized AMT, and there's some thought that there is some benefit to these cytokines. The studies really haven't been able to show that yet, but I think it's a great treatment option in an ICU patient that isn't otherwise ambulatory and isn't going to be getting drops quite as frequently. So I'm going to spend a few moments and talk about the novel approaches to treatment that have been published over the past 5 to 8 years, I'll say. The first is oxygen therapy. They had 2 studies, one that was done in Japan and one here in the United States, that showed if you expose the patient to 100% oxygen at 10 liters a minute for an hour twice a day, it actually improves the amount of limbal ischemia that's present in the ocular surface. The patients have a much rapid reepithelialization rate. The cornea tends to be more translucent sooner, and there's decreased corneal neovascularization. And this is felt to be as a response to the VEGF that's produced on the ocular surface after any sort of a chemical injury. If you can sort of overload the oxygen carrying capacity of the hemoglobin in the body and transport it to the eye, which is one of the highest blood flow rates to the body, theoretically it makes sense, and now 2 studies have shown that this is helpful. Logistically, this is hard to do because you have to do it for about 10 days, and that's not the easiest thing to do, is to either admit a patient or have them come and get oxygen twice a day for 10 days. One of the more recent things that was published was the use of topical infliximab, which is a drug which is also known as Remicade, at a dose of 10 milligrams per ml. This is a TNF-alpha inhibitor, again another pro-inflammatory cytokine. This penetrates into the cornea, so not only can it have an effect on the ocular surface, but it can help to decrease inflammation in the trabecular meshwork and within the iris stroma, where you can precipitate a pretty significant iritis from a chemical injury. The study has shown in a murine model that it's non-toxic inside of the eye, and I think this has also been shown in uveitis studies where they've been injecting infliximab into the vitreous cavity for treatment of non-infectious chronic uveitis. So in terms of a topical drop, the patients already have an epithelial defect in most of the cases, and it reduces the corneal perforation rate. And when they've studied conjunctival biopsies in a murine model, it actually decreases the goblet cell infiltration of the cornea and of the conjunctiva. So you get less conjunctivalization of the corneal surface in the murine models that were exposed to infliximab topically. Avastin can't seem to run out of novel uses, and for this particular case, you can compound a 1% Avastin solution, again as an anti-VEGF agent on the ocular surface, and it can actually regress some of the symblepharon and the neovascularization on the cornea. How long-lasting this would be, the jury is still out, but in an acute inflammatory situation, it seems like a reasonable idea. They haven't shown that there is persistence of an epithelial defect. I know there was some concern over the use of a topical anti-VEGF agent and possibly reducing the rate of the healing of the corneal surface, and this really hasn't panned out. It doesn't seem to delay reepithelialization. Unlike oxygen therapy, which will improve epithelial healing and will infliximab, Avastin as an eye drop will just sort of go along with the status quo. There is no difference between placebo and Avastin in reepithelialization rates. And the final approach is in patients that have actually had a pretty severe injury with corneal irregular astigmatism towards the late phases, is a PROS device, a scleral lens or prosthetic replacement of the ocular surface. I find this helpful in chemical burn patients and immunological burn patients in particular, where they've had pretty devastating corneal melts, and it actually does reconstruct the ocular surface pretty well. They're very challenging to learn how to use, and there are quite a few people that are now learning how to use these Boston scleral lenses for visual rehabilitation of these patients. But again, these are more late treatment findings as opposed to the earlier ones, which are more immediate treatment findings. So I'm going to end there and sort of take any questions and other thoughts on anybody that's sort of tried out any of these novel approaches and what their outcomes have been, if they want to share.